Sit and stay. So I believe the hour has arrived. I'd like to call the meeting to order. Let's have a pledge of allegiance, please. I pledge allegiance
to the flag of the United States of America and to the republic which stands one nation under God, indivisible, with liberty and justice for all.
Jessica, roll call.
Glenn Bailey.
Present.
Peggy Cavala.
Present.
Dr. Johnson. Dr. Nolans.
Here.
Commissioner Cowles.
Here.
Commissioner Bertling.
Here.
Chairman Fletcher.
Here. Public comments, although I don't see any public, so I guess that'll be brief. Consent agenda. Are there any?
May I say something?
Hello?
Hello, Mr. Chairman.
Ron, oh, I'm
Corn.
sorry. Yes, sir.
It's hard to see that little hand up there.
Oh, I apologize.
No, thank you. So I just had a quick question. I don't know if you're going to discuss it in today's meeting or not, but I see there's a free healthcare clinic coming up by the Sunshine Northwest that you guys are participating in at some level, and I was just curious at what level Panhandle Health District's participation is. And if that is on your agenda, I'm not sure if you're going to discuss that or not, but if it is, you don't need to, we don't need to discuss it right now.
Oh, okay. Well, it's actually not on the agenda, but we're in a position to respond to you, I think.
I'm going to defer it to Eric.
Oh, Eric. All right.
Okay, and Jennifer or Greg, fill in if I missed something, but it appears that we had attempted to initiate a relationship with the Sunshine Group a couple of years ago. They had inadvertently left our logo on their advertisement. So we don't have a relationship with that group for this event this year. Not to say that we wouldn't partner with them in the future, but this year we are not.
I can add to that. So I spoke with one of the board members a couple days ago, and what I recommended was that they activate Medical Reserve Corps to help them with some of their needs there. I sent them some instructions on how to request us, and as of yet, I don't have that request. Otherwise, I don't believe that there's any other participation at this time, but they are aware that we've asked in the future to just correspond with us as far as the logo is concerned.
Okay. Do we have a recognized person within our organization who can serve as a liaison?
In speaking with them, I've gone ahead and just designated myself.
Are you that person?
As of 2 days ago, I am now. So
Okay.
I'm the point of contact with them. So from here on out, if there's anything that needs to be relayed to them, I can go ahead and reach out to the board there.
Great. Greg, do you have something to add?
No, just that we've been in discussions about this topic for a couple of weeks now, wondering the same thing that Commissioner Corn was perhaps wondering, how the logo could be on their flyer. So we can address the prevent inappropriate use of the logo from happening in the future.
Okay. Well, if you'd be so kind as to maybe give us an update, I mean, on a PRN basis, as needed. All right. Thank you. Any other comments from the public? I apologize, Commissioner Corn.
Thank you, guys.
All right. Any other public comments? Any hands up? No? Then let's move on to Agenda 5, the consent agenda. Are there any items in the consent agenda that board members would like to extract for further conversation? Okay, hearing none, I will entertain a motion to adopt the consent agenda.
Mr. Chairman, I make a motion that we adopt the consent agenda as here presented.
Do I hear a second? Any discussion? Now, Jessica has reminded me that actually it's more appropriate that a board have an affirmative vote as opposed to just sort of, if there are any objections, speak. So moving forward, I'm going to let Jessica perform a roll call vote on all action items. This is what she would like. So that's fine with me. So Jessica, roll call vote. Look at that big smile on her face.
Glenn Bailey,
Yes.
Peggy Cavallo,
Yes.
Dr. Johnson. Oh, sorry. it's not here. Dr. Nolan,
Yes.
Commissioner Kells,
Yes.
Commissioner Bertling,
Yes.
Chairman Fletcher.
Yes. Okay. The next item is the election of officers, our sort of annual ritual. Let's just take the items as they are listed in order. Do I hear any motions for chairman? Yes.
I would like to nominate Glenn Bailey.
Okay. Do I hear a second?
I would like to second that.
Okay. Are there any other nominations?
Can you do multiple
Yes.
nominations and stuff? Is that the idea?
Yes.
Let's see here. I would nominate Thomas Fletcher.
Do I hear a second
For what position?
for chair?
I'll second it.
Okay. Are there any other nominations? All right. Hearing none. So let's have a vote. I mean, I suppose we could do this and we could do you want to do pieces of paper or just sort of vote one at a time? How do you want to do it? I don't. Why don't, do you have pieces of paper?
No, but I.
This is the way we used to do it. You remember that?
Well, we did it, and looking into it, I think that as a public body, we need to have it can't be a secret ballot.
Okay, fine. So be it. So we'll take them in order in which the nominations were made. So let's have a roll call vote for Glenn Bailey. Jessica, roll call vote.
Glenn Bailey,
Yes.
Peggy Cavallo,
Yes.
Dr. Johnson,
And this is a roll call vote
For Glenn Bailey as chairman of the board.
Oh, okay. No,
Dr. Nolan,
No.
Commissioner Kells,
Yes.
Commissioner Bertling,
Yes.
Chairman Fletcher.
No. I believe I think you're the chairman.
Hey.
Congratulations.
Was that the final count for me?
Congratulations.
Well, you got 4. I mean,
Oh.
4 out of 7 is,
Okay.
I believe. Yeah, isn't it 4 out? Yeah, he got 4. All
Yeah,
right,
you
you're
did
the
it.
chair.
You did it. Good job.
Okay. I guess under Robert's Rules of Order, it's appropriate for me then to conduct the remainder of the meeting. Is that correct?
I guess so. Yeah, sure.
I believe.
You're it.
Okay, item 6B, Board of Health Vice Chair. We'll entertain motions at this time for Vice Chair.
This is Peggy Cavallo. I'd like to nominate Tim Bertling for vice chair.
Tim Burton. Thank you, Peggy. Is there a second?
I'll second.
Okay.
Should.
Tim, it's seconded. It has been moved and seconded Tim Berkeley as chair. And, is there other nominations?
I'd like to nominate Duke Johnson.
We have a nomination. Is that seconded?
And second, Duke.
It's moved and seconded. Okay, are there other nominations at this time for vice chair? Hearing none, we'll entertain Commissioner Tim Bertling as vice chair of the board of directors. And take a
Glenn Bailey,
yes.
Peggy Cavallo,
Yes.
Dr. Johnson,
No.
Dr. Nolan.
No.
Commissioner Kells,
Yes.
Commissioner Bertling,
Yes.
Chairman Fletcher.
No. We now have a vice chair.
So Commissioner Bertling, congratulations or condolences, whichever.
It's, yeah. Another hat.
Okay. And agenda item number 6C, Board of Health trustee. And we'll entertain nominations for the trustee at this time.
I'll nominate, who?
Joel.
Yeah, I was going to do this within second.
Okay, it's been moved and seconded that Dr. Nolan be our trustee. Are there other nominations? Hearing none and seeing none on the board. Okay, let's take a roll call vote on Dr. Nolan as the trustee.
Glenn Bailey,
Yes?
Peggy Cavallo,
Yes.
Dr. Johnson,
Yes.
Dr. Nolan,
Yes.
Commissioner Kells,
Yes.
Commissioner Bertling,
Yes.
Chairman Fletcher.
Yes.
Great.
Sorry.
Congratulations.
Thanks.
Okay, that concludes item 6. Item 7 is the Finance Committee report.
Well, no, it's now you. That was kind of presumptuous.
Well, okay.
I can tell you what I was going to say,
If you could.
and then you can either choose to move forward or not. What I was going to say is, let's continue with the Finance Committee. I thought it was a good idea. And then I would also stay with the same personalities because they were sort of performing that task for only about 4 months or so. And then finally, what I would recommend is that we begin now with a more, shall we say, focused examination of the different departments, as opposed to waiting until February and then do a mad rush to prepare for the annual budget. In other words, pace it out.
Okay, and then provide recommendations again to the full board.
Yeah, sure.
After we have those
Conversations.
meetings.
Chairman Bailey.
So we've opened this for discussion this time.
Okay.
So,
Is this currently, is it yourself, Dr. Fletcher, and Peggy? Okay, and that's the current committee?
Correct.
Okay. Yeah, I think that being proactive throughout the year, I think would be most effective so that we can have time, because a lot of this stuff gets very detailed, nuanced, and it takes time to metabolize it and understand it. And Jason lives in it, and Kim lives in it and stuff, but kind of for us to be able to become more supportive and involved, I think would be great. So, yeah.
Sure, Chairman, if I may, I would support Dr. Nolan's comments. I think that this will allow more transparency for the entire board as far as ongoing budget and budget review. So if we see anything shifting, then we can get immediate direction from the board on how to adjust.
Excellent comments.
If I may,
Others? Yeah.
one more, I was just thinking
Dr.
that
Nolan?
what we kind of ran into this year, where kind of trying to anticipate for all the commissioners in the different counties, what information do they need to hear to fully understand it, so that hopefully next year when we get to the budget, the concerns or questions have already been worked out ahead of time, would be a goal, I think, to aim towards. So,
Okay. So standard format. for
yeah,
the-
and we could work on a format. We could even float it with the commissioners and say, does this make sense? Like, or something like that, so that we can come up with a very consistent, easy to metabolize
Yeah.
format
Get those inputs as well.
ahead of time would be, I think, ideal.
Appropriate. Very much so. Other comments? Okay. Well, that was not a action item, so I think we can all agree that process has worked well, and we can adjust it if needed.
The last thing I was going to recommend is that it has to, and the subcommittee can actually have this conversation amongst itself, but it was going to be my friendly recommendation that we have the time of that meeting immediately preceding this meeting, so that you only have to travel once. Because,
Good idea.
for instance, Peggy has to go some distance. Well,
Mhm.
this means she can, you can get a twofer, so to speak.
Okay.
It's just a thought.
It's a good idea.
Well, no, it's not a motion. It's not an action item.
No.
Good
He gives it a thumbs up. All right. And Eric, remind me, how many departments have budgets?
We probably have, well, we have multiple departments, but I guess maybe the most relevant comment is that I will work with Christine to schedule those meetings, and that we will have the agenda items within those meetings reflect what the fiscal subcommittee wants to discuss, so that we make the best use of their time.
Okay. And as far as timing, generally in the months leading up to the annual budget and presentation to the county commissioners, would that be best to hold off until several months before, or?
I definitely support having those meetings on a monthly basis, and certainly before the board meetings, particularly when there's a lot of interest and there's a big push for building up clinic. I think that will help facilitate those conversations with the board.
Okay. Any other comments, thoughts?
One other thing I was thinking is to, like a lot of businesses or organizations have different metrics which they can kind of quickly assess and figure out for each department what would be that metric, like where there could be like a one-page summary sheet with each department that would have several metrics that we can kind of track each week for everyone. And then also whether it's, one of them would be is total budget dollar value, total amount per employee, or these may not, I'm not saying these are the ones, I'm just saying something like that, or total number of revenue generating, fee generating events or sewers or restaurants inspected, or different things for each department, how many, within that month kind of thing, but where it could be broken down by each department so that we can all look at it and then have potentially generate meaningful discussion or questions. Because then you start to see
Standardized format.
yeah, what kind of questions should be asked. Sometimes if you don't even know what the data is, you don't know what question should be asked.
And we can pull, maybe that's a good first pass, is we can pull that data, the data that we do track as far as those activities, and how it relates to the budget, and then decide on how to best combine those into a meaningful metric.
Yeah, and then the department heads could possibly propose, these are some metrics that are important to them, and then those might be a good start to, I think.
Will do.
Okay, so if we do this on an ongoing basis, and you've got a standardized format that you use, Christine's not here right now, but think that we would be able to come up with things. Now, do any of your departments, their request for budget, is that influenced by things as far as grants and other things that come along later in the year that they won't have information on?
There may be some of that, but I think for the major programs, we can provide metrics. So we can, when we have that first meeting of the finance subcommittee, we can work through those details and bring those to the board.
I think that'd be good standardized format for us that the board is used to. Okay. All right. Well, thank you, Dr. Fletcher. Now, next item on the agenda is Dr. Pennock, the medical director's report.
I had three mainly housekeeping type items that I need help with the board with. The first is the fee schedule and the fee schedule policy. The policy hasn't been updated since 2014, and it's a little bit outdated. And I don't know, honestly, when the last time anybody looked at the fee schedule per se was, but I would venture to guess it's at least been a couple of years. So we've been looking at this in some detail recently, and we've had meetings with Eric, with Amra, who's our coding billing specialist. She's had tremendously good input on this. And so there's a copy of the proposed policy and basically how it differs from the previous policy. In the previous policy from 2014,
And Greg,
yeah,
are you quoting from a page number
26, sorry.
for reference? Thank you.
Page 26. So there is the actual fee schedule on page 24 and 25 for anybody that wants to look at that fee schedule. And that includes office visits, wellness visits, preventive visits, as well as not a comprehensive list, but the main procedures that the clinic performs. So this isn't absolutely everything that the clinic does, but it's the top dollar generators of the procedures. Let's say that.
Dr. Pinnock?
Yeah.
Is this what would be billed insurance, or is this if it's a cash pay show up? And is there any difference?
There's no difference. It would be
Okay.
billed to insurance. Insurance would likely not pay that, or they may pay that
Okay.
number. Same with.
So if a cash
Medicare.
patient, someone comes in with self-insured or whatnot, then they would
That
pay
would
this
be,
price
that would be
directly?
the price.
Okay.
Yeah, unless they're on the sliding scale and they have shown,
Okay.
they've demonstrated inability to pay because of low income, and then they would pay based on that sliding scale.
Okay, thank you.
So, Dr. Pennock, my review of the current fee schedule and the proposed fee schedule, I see several that are proposed increases and others
Right.
that are proposed reductions. Now, how do we arrive at these proposed fee schedules?
Right, so that's the key. And so the policy change has to do with the methodology of how to calculate those fees. So previously, the 2014 board decided on two methods to try to calculate the fees. The first method was based on relative value units, which are basically work units that Medicare uses and attaches a number to come up with a fee for all evaluation and management codes and the procedures. There's a fudge factor called a conversion factor that multiplies by this rather extensive formula and ultimately determines the fee based on Medicare rates. So that's the first method that was
Okay.
used in 2014. The second method was the Medicaid schedule, which basically sets fees at 150% of the current Medicaid allowable. So that's what is in the current policy, are those two methods for determining fees.
Okay.
What's actually happening in practice is that are those two methods being used, but also a reimbursement method, which is E under the procedures proposed. And that method consists of fees being set by the actual dollar amount that private payers will reimburse us for those services. And that that applies mainly to procedure type of services.
Okay.
So those three we're already using, A, B, and it should be D, not E. That was the typo. So there's four of them, A, B, C, and D. So we're using A, B, and the last one, the reimbursement method. The proposed also adds an expense-based method or a cost-based method. And basically what this does is is an analysis to look at our actual costs as best as we can through time spent from the practitioners, through the cost of any pharmaceutical or any vaccine, for example, and then calculate a fee based on that, based on our true expenses. And so you can see what goes into that: direct expenses, medical supplies, pharmaceuticals, consumables, staff time, equipment depreciation or rental, and indirect expenses. So the way that we calculated it to come up with some of those cost expense-based methods was to take the indirect expenses at 150 at 50% above the true cost. That 50% was similar to what had been done in the past with Medicaid, setting in that 150% of current Medicaid allowable. But this allows us to capture the true cost of these services better than it has been in the past.
So you feel that's more efficient method?
I think it's more efficient, and it also covers our true cost better, so that we don't, our goal is obviously budget neutrality, and if that's our goal, which I think it is, then getting close to that. One way to do that is with the fee schedule, to set it at an amount that will cover our true
Cost
costs.
of doing
Yeah.
business.
So it gives us a little bit more flexibility in the fee schedule.
Dr.
And
Bennett,
it also reflects what we're actually doing currently better.
for clarification, you were mentioning that there's like a Medicaid max. If you set it at 150% or 175% or 200%, do you still only get that Medicaid max regardless of what price you put on there?
That's correct. For
So then-
Medicaid patients.
So for Medicaid, it won't really change it, but for all private payers and possibly Medicare, we would potentially get more close to our actual cost coverage, knowing that we still are going to get the Medicaid max,
That's correct.
but we're not going to get closer to our cost coverage if we don't actually set it at the actual cost of
That's
doing
exactly
business.
right.
Okay,
Yeah,
thank you.
exactly.
All right.
Chairman, can I ask a question?
Yes.
Clarifying question. So,
Sure.
one question that I certainly support the review and capturing actual costs. But I did have a question, and this is, some of my just trying to understand how fees are set. Is the same methodology one of the four methodologies used? Is the same one used across the board, or are different methodologies utilized in different fee categories?
Yeah, well, different methodologies are used for different fees, and that's not my doing. That's what has been going on prior to me going there, and I think it's appropriate. For example, the office visits are mainly based on the Medicare, the RVU method. Some of the preventive services are based on the Medicaid method. A lot of the procedures are based on the expense-based method, the way that they're listed. So it is, again, it allows some flexibility. There are different methods for different categories at least.
And just to, I guess, clarify the expense-based method, because we did speak about this last week when we chatted, and there was the discussion on actual fee plus 50%, but are we in that category? It looks like that was removed, that 50%. So in that fee methodology, is that an assessment of actual fee considering overhead, indirect, the whole 9 yards? Is that what that?
I think
reflects on?
the 50% would reflect overhead. And based on my discussions, emails with Christine, overhead, indirect expenses for the clinic in general is around 47%. So it's not just taken out of thin air. It was a pretty good approximation.
So it's an estimate of actual expense, not an actual calculation of.
Well, so it's a percentage of, so it's the actual total cost plus the 50%, which accounts for indirect expenses. So it's actually pretty darn close to our true actual expense.
Can you give us an example of indirect expenses, just to clarify that for everyone?
Eric can probably answer it better than I can.
Mhm.
You want to?
Indirects are usually, it's based off of employee salary in a given department, and it's items that are utilized across the district: phone systems, IT support,
Okay.
facilities, electricity. that
So it's kind of the cost averaging associated with that aspect of the clinic from the total building structure and everything.
And I guess the reason that I ask is that I have a fair bit of familiarity with calculating actual costs for service from, work and environmental. And what we do there is we typically do an ongoing and an actual look back based on program cost reports. So instead of utilizing an estimate, I do believe that we have information where we can actually pin down actual cost. And I think we chatted briefly on that. Maybe that's something, the way this is worded, we can incorporate.
And Eric, too, one of the things that may be good to look at is how those are being calculated, what formula is being used to assign costs, and see if that's still, because that's, obviously the clinic is different than what it was 5 years ago or 10 years ago. And so to see how much of it actually should still be put on the clinic at this point versus any other department, kind of reevaluating that formula, since it's still a formula that's generating the actual,
We could, discuss this with Dr. Pennock further.
yeah.
And I guess while we're on it, I just did have one more question as I was reviewing the fees. I saw two that seemed to be a bit of an outlier on the fee schedule on page 25. One was, I guess, about a third of the way down, and it was the COVID vax injection. It looks like that went up substantially. And the second one was the Loletta IUD, which went down substantially. And I was sort of curious the way those moved so much. The other one sort of made sense as far as incremental movements up or down, largely up.
The Loletta IUD is an oversight, and that should not be lower than the current fee schedule. So we'll have to look at that. That $158 amount is wrong.
Is it missing a zero possibly?
Possibly. Yeah, it's possibly missing a 0 or a 1 on the other end. The COVID vax represents actual costs, and there's administrative fees and other things tied to that, but that's actual cost.
Has there been a reimbursement rate change because I think originally during the state of emergency, there was most of that was covered. So has there been any shifts in that in the last year or so? Or
To my knowledge, adults have to pay for that.
That's my understanding. Yeah. Part of that, Eric, might be that the willingness for those to be paid for has shifted a lot in the last 2 years.
And I did.
So we'd have to look at the exact causes of that. So
I did take a look at the sheet that Amber prepared showing reimbursement rates from various insurance companies. And it does look like the reimbursement rates from most insurance companies, I believe even Medicaid, was about $40 for that portion of the procedure.
So then what's the cost of staff time and the actual?
Well, I guess what I'm saying is that we can charge what we want, but those folks that have Medicaid, Medicare, or other coverages, what we're going to actually receive is going to be $40.
Mm-hmm.
anyway, I'm sorry.
Question is, do you remember approximately percent of total patients that are Medicaid?
Not off the top of my head, but
Okay.
it's probably a quarter.
Quarter, okay.
Peggy, I see you got your hand raised. Would you like to make a comment or
Thank-
question?
I have a few questions regarding this item. The first is that I think there should be separate action items. I think the fee schedule is one thing, and I think the change in policy is another. And it seems like, we had a meeting recently where we had a very long discussion regarding changes to the proposed bylaws. And we went through everything line by line. And at that time, I think it was established that the medical director is still under the health department director. So it seems like it should be, the actual policy should say on number 2, reviewed and formally approved by the medical director and director. And I know we still haven't followed up on that item from a previous meeting regarding the bylaws where we all went through line by line. So that was one thing. And the other thing, if we're raising fees, because I know every insurance company reimburses differently, and I can't even imagine how many insurance carriers we're currently billing. But I know there's kind of like a fine line with reimbursement, because if you go after the insurance that allows for the highest reimbursement, then what you end up doing is for all the other insurances that don't allow reimbursement at that rate, you actually just increase your contractual adjustment. Meaning, yes, this is the service we provide. Let's just say it costs us $2,000, but the insurance is only going to pay $1,500. So then that $500 goes into that contractual budget. And I kind of wish Christine was here to answer that question, because I know there's sort of a fine line when you make these fee changes.
So if you set the fee schedule at an amount that's lower than what the insurance company is willing to pay, then they'll pay that fee. You'll never
Correct, but
if you
correct,
set it
you
high
don't-
enough, you'll never collect what
Well,
the
you-
insurance
you-
company might
if
be
you-
willing to pay.
Peggy, is it okay if what you're saying, see if I understand it?
I'd like to repeat myself.
Okay, go for it.
And maybe I can make it clear. Every insurance company reimburses differently. And it's trying to figure out the sweet spot for that reimbursement. Because if you're asking for a certain dollar amount and say, yes, there's an insurance company that, maybe 10% of your patients will give you that upper level, you still have to, the fee's the fee, and the reimbursement is the reimbursement. And I think that's what is one of the most confusing things for healthcare is, people don't understand that we can set a price, but that doesn't mean we're going to get that price. You also have to be careful with those contractual adjustments.
So I'm
So I'm
not sure
just
what
saying,
Can you
fees
expand on
are
the
balancing
carefulness
act.
on contractual budget? Because you said that a couple times, and I don't understand the caution needed to be on that. If you could express me your thoughts on that part, so I can come up to speed with what you're saying.
Most medical practices have, you can look at your gross. So this is the money we expect to make. And then you look at your expenses. This is the money we made. Well, the contractuals are part of that expense, because you say you billed for something that costs $2,000, but the insurance is only paying $1,500, you still have to account for that $500 somewhere in financial reporting.
So Peggy, there's a couple ways that I understand, and you can let me know what your experience is. But there's the balance billing that occurs. So where the insurance says we're willing to pay the $1,500, and now the patient has to pay the remainder $500. That's one way that it happens frequently. And then the other one would be that it's written off, and then Christine would know how to do that with the balance sheet and the budget and all that stuff like that.
That's actually what contractuals are. And most insurance companies, you are billing an insurance company, you're saying we're going to accept your fee, and you don't go back and charge the patient. You're accepting their fee.
That's not the standard with any laboratory like LabCorp or Quest, the two main in the country. They definitely balance bill, and they are billing insurance most of the time. So if there's a $2,000 insurance ask and they're only willing to pay $850, then the insurance company requires the lab to then collect the balance from and it happens all the time to my patients. So that is a standard of practice that occurs. And it just depends maybe on the policy. If an office has chosen to not balance bill, or if for some reason a given contract prohibits balance billing. But other than that, it is actually a common practice that I see normally. So not that it should be done. I'm just saying that is something that I have experience with being a normal thing. So I would like your input on that too. We're just going back and forth here. So
Let me see if I can clarify.
What I'm saying is that,
Peggy, can I clarify just for a second?
yeah.
Yes, so Panhandle Health can set the schedule at what it wants to. Insurance is going to pay us what they want to. And the difference is your contractual adjustment. From Panhandle Health standpoint, we want to set the fee schedule high enough that we collect everything that the insurance companies will pay. We don't want to set it so high, though, that the people paying out of pocket are being penalized. We want to keep those fees reasonable based on the population and the public that we serve. So I think that's kind of the balance that we have to make. The contractual adjustments are simply paper adjustments. They mean nothing in terms of the money that we collect. It's simply accounting, and it goes to thin air. There's no practical use of measuring, and you can't write off the difference. No medical practice can. So basically the difference between what you bill and what you collect is the contractual adjustment that you're talking about, and that goes into thin air.
Yeah, I just wish Christine were here to answer that.
And Peggy, if you said that you have to be careful about the thin line, because my thought is you set one of the best things for a business to do is set their prices at the cost plus whatever. If it's a profit business, whatever it is, and if it's not, then you're trying to go neutral. And then, like Dr. Pinnock was saying, is the insurance company will pay what they will pay. And then, but if we can get the closest we can to our cost, then it saves the county's money and the taxpayers' money too.
I understand that. What I'm saying is every single insurance company often sets a different price.
Right. But like he's saying, that it doesn't really matter what each insurance company sets. If it's equal to or lower than what we set, we'll get whatever they pay, but if we set it lower, so if an insurance company will pay $1,500 for the procedure you're talking about, but we set it at 15, they may only do 80% of what you ask or something like that. And then we may only get 1,300 or something in the department. And then we're now passing $200 more onto the county and the taxpayers. And so that I think is part of what we're trying to reduce that if possible. Does that make sense, or is that true what you're saying? Or?
Yeah, no, I think that's a good explanation. If you set the fee at $1,500 and they would have paid $1,700, they're going to pay $1,500. So we've lost $200. So you want to set it high enough to capture those payments, but you have to, as I said, you have to be careful that we're not penalizing the people who pay out of pocket.
Is there a clarification on how that would penalize them? Like what factor how they would be penalized?
Well, I mean, they would have to pay what we set the fee schedule.
So they would do the
Yeah, so-
balance bill, basically, you're
And
saying?
do
Or
balance billing. Now that's.
how do labs do that all the time?
I don't know. That's a good question.
Yeah, they do it all the time. Yeah.
Okay.
So.
Well, Peggy, you brought out some excellent points for discussion. And one of the first things you said was item number 2 on the proposed procedure should also specify the medical director or proxy and Panhandle Health District Director. Is that correct?
Yes.
Okay. So, I like that proposal. Is there any other comments on that?
So what was the proposal, just for clarity?
Item number 2, where it says the specific service procedure, CPT code, or E&M fee will be determined by the medical director or proxy, and would also include the Panhandle Health District Director.
Well, one of my thoughts would be is that it depends on how the running goes on that, is the determination would likely be the medical director and then have it approved by the Panhandle director. But I mean, normally you'd have
It should
your
be a collaboration of it. right?
potentially depends on the Panhandle director's closeness with the material too. So,
Mhm.
you know, and understanding,
Okay.
because like that's why if you have specialists as a leader, you have them come and tell you and basically do the math for you, and then you work it, make sure it makes sense, and give them, we'll adjust it here and that kind. That's my thought.
Yeah.
But
Mhm.
yeah,
And Chairman, I would appreciate that, as I would certainly defer to the expertise of those setting the fees, but I would
Sure.
appreciate an opportunity to understand it.
You need to be active participant
Right.
in the
Exactly.
process.
Yeah, so I can,
Sure.
certainly defend the fees if they come to mind.
sounds good.
Okay. So do we have a proposed modification for that phraseology? Peggy,
Well, I'm looking at it. That's why I thought really, I think if this was divided, I really do think it's 2 issues. I think there's a policy issue, and then there's this proposed new fee schedule. I think they're 2 separate things. And I don't know if it's an issue to bring the procedure, it's procedure and a policy almost, it looks like, but bring that back next month as an action item.
Chairman, can I ask a question on that?
yes.
So
Dr. Nolan.
there's 4 proposed methods for calculating,
Right.
I think, right? But this doesn't define which method was to be used. So it's more of a just explanation of 4 potential methods that we could use. So I don't know if part of this, and Peggy, maybe you can see what your thoughts are, is this supposed to be choosing one of these methods, or these the available methods that we're okay with the medical director and the director utilizing, but it could be any one of them. So or do we want to say, hey, we prefer primarily doing the space to there?
Yeah, so my recommendation would be the option to use any of the 4. Currently, we're using 3 out of the 4 anyway.
Okay.
Despite what the policy says, based on 2014, we should be using A and B. Prior to me getting here, that was changed along the way, and the reimbursement method is being used. And my proposal then was to add the expense-based method.
Okay.
But I think to give the people setting the fee schedule, whomever it is, some leeway, I would recommend that any one of the 4 be utilized.
So you see a need for different methodologies at different times?
I do,
Okay,
Based on the situation and service provided?
based on the service provided.
okay.
And Chairman, if I may, I did reach out to other districts and they do utilize that. They have multiple methods and they utilize it depending on which one's most appropriate. So I would support
Okay,
Dr. Pennock.
sounds good.
Okay. And this is in line with best practices that we're aware of?
To the best of our knowledge, yes.
Okay. Any other questions, comments? Okay,
Well, to Peggy's point, are we with this action item, the way it's set up, does that mean that we vote on the fee schedule, the no-show policy, and the clinic service? Or are we just talking about the fee schedule, but not how it'd be generated in the future?
okay. So,
Sorry, not to try to confuse the situation.
Chairman, I guess what I would say in looking at the agenda, I don't think the methodology for determining clinic fees is specifically listed. I believe that the fee schedule is one item, the no-show policy is one item, the out-of-health district policy is one item, and then the methodology is an item as well.
okay, so this
Well, the
proposed
methodology is
needs to be
included in the first
revised.
one. Well, the methodology seems to be included in the first one. I mean, it's already there, so I mean.
It's kind of how it was generated.
Yes, yeah, in other words, it's already there.
being considered. Okay. So is there a proposed modification? Or do we want to put this off? What's the timeline?
The
Do we have-
timeline is soon. I would recommend.
Yesterday?
Yesterday, I would recommend that we approve a fee schedule because that's obviously going to start tomorrow.
Okay,
So just so I can check, treating each one of these as their own action items, A, B, and C, or
I would,
I would recommend you treat them separately.
yeah,
Yeah.
okay.
as separate action items. Excellent. Okay. So the first action item would be,
So the idea would be is
The recommendation would be to approve the methodology,
mhm.
which really encompasses that fee schedule.
So can I make a motion then?
well, do we need to further discuss the follow-on separate action item? That was one, approve.
So,
I think the policy needs to be separate from the fees. That's my opinion. The fees are one thing, the policies are a separate issue.
Okay. So the proposed policy here,
are you referring to the patient out of health district fee policy, Peggy?
I'm referring to all three of the policies.
Oh, I see. So you're thinking of treating those
So-
each individually?
so first is the methodology, the second would be the specific service procedure,
Mhm.
and the third would be all clinic fees shall be reviewed at least biannually. Is that correct, or is it biannually?
Should be here.
Is that frequently enough?
I think so. We talked about annually, although it would be a lot of work to do it annually. So I think every other year is reasonable. As I said, I'm not sure when the last time somebody looked at it, but I do think it's something that should be looked at least every other year, should be brought to the board for discussion, approval.
Okay.
Just because these things change so frequently, yeah.
Could be brought up even more frequently
Yeah. If needed.
if needed
But this requires it to be brought up every 2 years, and then it can be more frequent if we need.
for review.
Sure.
Okay. That's fair.
Okay,
I would make a motion to approve this fee fee schedule. Again, it can be adjusted per a policy we're talking about, but for now,
Okay.
since it's a request as an urgent matter.
And with the proposed modification of item 2, that the director, consultation with the director be also included here, correct?
I could add that in there, that it's explicitly that the medical director and the Panhandle director would both together approve that for then prior submittal to the board.
Okay.
So a joint effort.
Okay. Peggy, did you have further comment? Or, okay.
For a second.
The motion has been made that we approve the Panhandle Health District procedure as here outlined with the modification that item 2 include the director in the consultation there.
Mhm.
And that was it.
That's it. Other than that, it looks okay to me. I don't
Okay.
think Peggy's brought up any concerns on that.
Is that motion
Well,
seconded?
are we excluding then the no-show and the,
Those will be next, Peggy. Yeah,
um,
that's a separate
okay,
item. I
great.
think per your
Okay.
recommendation, I think it's good.
great. Okay,
Okay, so Dr. Nolan has made a motion.
I'll
Is that
second it.
seconded?
I'll second it.
Has been seconded. Okay, so the motion is that we approve the Panhandle Health District procedure as here outlined with the modification of item number 2. And is there any discussion on that? Hearing none, all those in favor of approving the Panhandle Health District procedure as here presented with the modification of item number 2, say aye.
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 um,
Any opposed? Hearing none. Okay, that motion is approved. Now, the second part. Yes. Dr. Fletcher.
Jessica had requested that we do roll call vote.
Oh,
Don't blame
thank you.
me.
Thank you for the reminder. Okay. I've been reminded we need to do that as a roll call vote. Jessica, would you like to?
Yeah, my time to shine. Peggy Cavallo,
yes,
Dr. Johnson,
Yes.
Dr. Nolan,
Yes.
Dr. Fletcher,
Yes.
Commissioner Kells,
yes.
Commissioner Bertling,
Yes.
Chairman Bailey.
Yes. Thank you. So that motion is been approved. And the second issue here, that we're breaking that up into 2 items, correct?
I think the request was to have B and C as their own items, line items, each one acting as an action item, I believe.
Out of procedure 1.
So B would be the next one, the no-show policy.
All right, let me explain the no-show policy. As far as I can tell, there's no patient no-show policy for the clinic. The reason we want to institute this is there's a significant problem with no-shows in the clinic. I went back and looked between for fiscal year 26, that is July 2025 to June 30th, 2026, there were 1,149 no-shows.
Wow.
Yeah, 16.4% of scheduled patients were no-shows. So the purpose of this policy is to try to reduce that number substantially because there's a real cost to that, and I can get into what that could be. So the policy would be that we would charge patients a minimal fee of $10 if the patient fails to cancel or reschedule an appointment later than 1 day prior to their scheduled appointment, and then the patient doesn't show up for their scheduled appointment. There'd be some flexibility that we would maintain on a case-by-case basis depending on the circumstances. So if somebody got in a car accident or had a family death or something, some
Something beyond their
unforeseen
control.
circumstances out of their control, then certainly we would cut them some slack, and the decision not to charge that fee would be made by the front desk at the time that they came in and pled their case. If the patient is a habitual no-show patient and they don't show for 3 consecutive appointments, then Panhandle would reserve the right to terminate the relationship. Now, since I wrote this, there's probably one more point that needs to be put in there, and that has to do with Medicaid patients. So I think we're on clear footing in being able to charge fee-for-service patients, insurance patients, and Medicare patients a no-show fee. I don't think we can do that for Medicaid patients based on the Idaho Medicaid rules. So I would propose that there be a 4th point, and I'm sorry that I didn't add this, but something to the effect of, unless Medicaid rules change, Idaho Medicaid members are exempt. Now, I would still recommend posting a sign that says it is Panhandle Health's policy that we charge a no-show fee as a deterrent for everybody. But we wouldn't be able to charge Medicaid patients that fee, as far as my understanding of the rules go. So I can go into more detail about what we lose by monetarily put some numbers to it, but that's the essence. You can see that if we have 16.4% no-show, then that's a problem we need to solve.
And Chairman, if I can comment on that, and
Yes, Eric?
Dr. Pinnock and I did have a discussion, and I did express some concern that statutorily we're only allowed to charge the actual fee for a service provided. I don't know if no-show qualifies as a service that we can charge for. Again, I support the premise of trying to motivate folks to attend their appointments. When I reached out after Dr. Pinnock and I spoke, I did reach out to the other health districts. 4 responded. None of them currently have a no-show
Policy.
fee policy or fee. Well, they have policies, and some aspects are incorporated. If someone no-shows for 3 times, then they, reserve the right to discontinue service to those individuals. But I guess my thought on that is to make sure that we're in statutory alignment with what we can charge a fee for.
So let me
Good point,
address
Chairman.
that. Let me address that, because so the argument would be we can't charge for a service that's not provided. But the Idaho statute doesn't say that. The Idaho statute says health districts may exercise the following duties or powers, and the number that everybody cites, the other health district cited, was number 11. They may exercise the following duties or powers to establish a charge whereby the board agrees to render services for an amount reasonably calculated to cover the cost of rendering such services. So Panhandle Health Clinical Services currently do not render services for amount reasonably calculated to cover the cost of rendering such services. Thereby, the county has to support the health district. So by definition, we don't.
Can I jump in on that?
So let me just finish and you can.
Sure, go for it.
Dr. Nolan. So the true cost of it is really the inability to schedule another patient in that patient slot. And that's a real cost. The dollar amount is the potential charge that could have been billed for that patient had the patient kept the appointment, or another patient that could have filled the schedule. So let me just put that number of no-shows, 1,149 no-shows in fiscal year 26 in perspective. If the average visit is about $200, and you could argue it plus or minus, but that's $230,000 in lost revenue. Also, there's an access to care patient issue. So patients who do not show present a barrier to access of care for other patients that are seeking care. So it's multifaceted, but I think we're actually well within Idaho statute. I think it was actually with Idaho Medicaid rules.
Okay, so would we need an attorney's consultation on this?
And Chairman, that's essentially where I landed there. We can all read the statute and we can make assessments, but as the administrator here,
That's a best
my
guess.
recommendation is that if we're going to charge a fee, and it has not been done by any other health district or yet vetted, that it makes some sense to get a legal interpretation on that.
So I think that probably not a normal lawyer, because just because you're a lawyer doesn't mean you know an area, just like a hand surgeon doesn't know brain surgery. And so I think best might be to talk with Medicaid administrators or some actual more administrators that know the policy and what's currently flowing through versus
For consultation.
otherwise if you hire a lawyer that doesn't know, you're paying them to be educated. And so it can cost you 2, 3, 4 times as much as it should if they don't already know. So, but if we can go to more of one of the administrators in the state that actually works with these policies, I think that'd be a good place to start first. And then if we can find a lawyer that actually knows that can answer it in 30 minutes, which is then that we pay equivalent
Save
amount.
us the cost of the
Yeah, so I think that,
attorney that may or may not.
yeah, versus just talking to a lawyer. I think there's time to talk to a lawyer, but just talking to any lawyer, I know that a lot of times you end up not getting necessarily what you need and you pay a lot for it. So
Good
unless
point.
they're the specialty in that area. So I'm a fan of talking to the specialists in that area.
Eric?
And Chairman, I was just going to say, I can certainly also reach out to other state entities and see if they've already vetted this concept out and if they're already charging.
And Chairman, if I could comment, I think Dr. Pinnock, you did a great job on talking about that. And I totally agree with your points on the cost, but the cost is also the time it takes to get them scheduled, which is this front staff time. And rarely is there one call. It's usually multiple calls. And so you have that time to even get them there, all of that stuff. And then like the reason why ER costs so much is because there's standby staff in case there's an emergency.
Again, I completely agree with the premise.
So I think
Not disagreeing with it.
Yeah.
whatsoever.
What's reality?
yeah, cool.
I just want to make sure that
Thanks.
we can legally charge this.
Sounds good.
Okay. Dr. Thomas.
So I'm certainly sympathetic to the lost opportunity cost. I think there's a psychology here that we might want to be mindful of. If you just sort of surprise someone with a missed appointment cost, that may not be received well psychologically. Do we currently have a no-show policy whereby we inform patients at the time they make the appointment
Good point.
that if they don't make the appointment, then they will have one other opportunity to make an appointment. And if they miss that one, then they've forfeited their opportunity to actually receive services from Panhandle Health. Do we have, okay, so
We
I'm
don't-
going to
As far as
propose.
I know, we don't have any.
Right, so we have no policy at all. So, look, in the group that I used to work for decades, we didn't have a no-show penalty cost. So you schedule someone for a shoulder MRI and they don't show up for their shoulder MRI, I eat the cost. We didn't charge that patient even de minimis for a no-show. Now, if they did this repeatedly, then of course, go somewhere else for your medical imaging services. My apprehension here is you might actually alienate people. And so I would propose as a policy, not that we charge a late fee or no-show fee, but that the policy be that you are given not 3 strikes, you're out. How about 2 strikes and you're out? You miss a unexcused appointment, fine. You want to set it up again, but no, going forward, you miss it again, well then, Panhandle Health is now no longer your clinic of choice. That would be my, and I'm reminded right now, the city of Sandpoint is attempting to implement parking charges. And I'm here to tell you, the people that have received tickets for parking too long are livid mad. I mean, the commissioners are going to hear it. The city council is hearing it. So when you dump charges on people, just beware that there can be ill consequence. Those are my thoughts.
That's a good point.
So Dr. Fletcher, if we had such a policy, would we advise them of that to begin with or
Yes.
after the first strike?
No, you might even tell them right up front. That way it would encourage them not to miss the appointment. Just when you make the appointment, say, by the way, our policy is 2 strikes and you're out, not 3 strikes.
Chairman Bailey, can I comment on this too
Yeah.
from experience?
Dr. Nolan?
Implementing a late policy or a 2 strikes policy, whichever way you go, requires a lot of communication. It requires a gracious rollout. It requires lots of communication because, again, if people have been trained in another way, it just takes time to retrain everyone, including the front staff, to make sure that they're now, educating on visits. So that's one. The other one is if someone is a new patient and they no show, which is probably gonna be more likely than if they're already a very consistent patient, they may not give you their credit card or their card. So then you have no point either way. So you have to then look at and say, okay, this is what we do is you have a policy, and I don't know what our software does as far as patient interaction, but you have a policy that they sign specifically sub from all other policies saying that I am pre-authorize a late charge on my card, and they sign it in person or digitally, such for this amount if I do a late fee. So they pre-authorize it and they acknowledge that will happen. And then, because you can't legally, I mean, you could probably try to get away with it, but you're in weak standing if you just bill on their card and you didn't get a pre-authorization for that. So I think that the idea is that that would be more of a way to roll it out, and it would have to be training on staff, education. Does our system currently do email and SMS reminders for appointments?
Not email so much as this and that.
So I think that email policy and then SMS, and in the SMS, you can even have a reminder in there, just remind you that and that would be after they already signed it. So it really requires a premeditated signing of it in order for it to happen fairly smoothly. And when that happens, almost all the people don't like it, but they're not livid because they pre-authorized it and they know, and they see it, they go, oh yeah. If they say it, I don't like that you did that, you just say you pre-authorized it. They're like, oh, you're right, I did. So usually that shuts down the upsetness of it. But if you just go and just bill without having some sort of official thing that for a service that they don't think that they got, then that's when that emotional pattern comes out usually. So that's from years of doing that. So,
Excellent points.
yeah.
Thank you. Okay, we have online, is it Peggy?
Yes, I just know historically, because the no-show rate has always been a problem. And, some people actually have, transportation issues, childcare issues, et cetera, et cetera. But I know the policy years ago used to be, if you no-showed 3 visits, then the only appointment that could be booked would be a same-day appointment. Because people tend to, people would still no-show sometimes for same-day appointments, but, it seems to work better, the same-day appointment. And I don't know, Dr. Pennock, do you know what's currently being done?
Not specifically. I think it's case by case, depends on the circumstance.
Okay,
That's why I'm looking to the board for some deterrent guidance. This was my proposal, but I like what I'm hearing in other proposals. So
okay, so it's been suggested that an actual fee wouldn't be appropriate. Is that correct?
Well, I think that was the original suggestion. I think a fee is appropriate because there's the concept of no pay, no pay attention. So
Yeah.
even if you pay $1 or $2, people don't like to miss something, then, even, I mean, that $10 is a very nominal fee, doesn't even cover getting them into the front door as far as the clinic operations and the time and all that. But it is enough of a little bit of a pain point without being an incredible burden that I think that's reasonable.
So the steps to achieve that fee, like you say, you got to have their credit card information or something.
It already has to be stored and ready to go.
Yeah.
Yeah. And authorized, pre-authorized. So
Okay. And online, Peggy, do you have a comment?
I just wondered if Dr. Penna was aware of what the no-show rate was for Medicaid clients, since they're going to be exempt.
It's a good question. If it's about a quarter of all patients, it's probably a quarter of 1,149 patients roughly.
it would be good to try to
I can tease
double,
that out
yeah,
and get
yeah.
an exact number, yeah.
Okay. So if you can get us further information on the fee policy and Medicaid.
One other, just to throw it out there, for habitual late people, instead of firing them, we gave them the option of you can prepay for your visit up front.
So that would be the consequence.
Yeah, if you've missed 2 times cold with no reasonable excuse, then we'd be happy to see you, but you must prepay for your next visit.
Policy, you
Yeah.
need to have a
And that way you're
card
not
on
shutting down someone who, for whatever reason, maybe just has bad time management.
Yeah.
And but they realize, okay, and then it's a point of an option and an educational point for them. So that, I don't know how that would work with the whole, insurance stuff, but that's just another thing that does work where you don't have to abandon the patient.
so advised consent on the fee.
Yeah. So there's an option to think about. Not that we'd be incorporating that right now.
Right.
So.
Yeah, dude.
My thought would be is that if the training of the staff was done appropriately and kindly, and I think that the $10 fee, if they just say, we just want to remind you that now that you've made this appointment, we do have a $10 no-show fee because it does cost us if you don't show, and I hope you understand that. Most people would say, yes, we do understand that. So if they just have that in the back of their head, I think sometimes that, even though it's not a significant amount, it does drive people to say, well, I don't want to waste money. I mean, but I think the financial impact of how it would impact the clinic would be huge, and so if they're already notifying up front and we just want to let you know in advance, be sure to call in advance so that you don't get charged that extra fee. I mean, I think you can do it in a really nice way where they're not like overwhelmed, shocked, call back screaming. If it's already mentioned 2 or 3 times, I think it would divert a lot of no-shows, which would substantially impact the income. So I think it's worth at least a try. And we got a bunch of yelling and screaming back. Okay,
Yeah.
let's stop it. But I think it's
I like that idea too. Eric?
Chairman, if I could, since there is a number of questions related to charging a fee and there are some options that have been presented, my suggestion would be that I work with Greg on some of those options and bring them forward to the board. But for today's purposes, maybe we just focus on number 3, which speaks to Dr. Fletcher's point is that we formally start informing clients that we have a three strikes and you're out policy. And so we implement that immediately, and then we come back to the board with additional information and options related to a fee.
Okay. I like that idea. And now, is there a standard terminology that we want our staff to use as they communicate with the patients?
Sure, we can
And
come up
you
with
could
that.
come
and
up with that?
I like Dr. Johnson's suggestion. It doesn't
Yeah.
have to be confrontational. It
No.
just has to be a
Just
deterrent.
be
And
advised,
that can
this
be-
is our policy.
That can be in 2 forms, verbally when they're making an appointment and so forth, which is great. And maybe a little sign at the time of checkout that says, you know,
Yeah.
so that they see that or check in every time they see it. It's, oh yeah, I forgot that there's a no-show policy now.
Okay, so you and Eric can develop that,
We can do that, sure.
okay? And do we want to consider that before our next monthly meeting or at the next monthly meeting?
I thought it's I mean, it's, how many do you say we've lost? I don't know, like 1,600 or something?
We're on a
1100.
timeline trying to get this
Yes.
policy into effect,
You
correct?
know, I guess what I'm looking for
How
is,
about we authorize you
Mhm.
and the director to come up with the phraseology and the policy, and then we could approve it or ratify it at the next meeting, but authorize them to go ahead and develop that now so that we're not delaying it.
You're talking about the staff scripting, so they know consistently between staff members how to communicate in a kind,
Correct.
but
And-
firm way.
And are we all in accord with the $10 fee?
Chairman, I think the fee is still in question as far as the legal aspects of it, but
Okay, and you will be consulting with the other health districts.
yeah, we can get I guess how I would simplify it is that Dr. Pennock and we can come up with a non-fee procedure without board approval. But if we have a
Okay.
fee that's going to be assessed to an individual, that has to go through the board. So I would say Dr. Pennock and I work on a procedure to implement immediately to start informing individuals, and then we bring a fee policy back to you after we've done vetting and we provide options.
Okay, but we've already got the 3 strikes, you're out.
if I could pick up on your point
Yeah.
and say if we could at least pass maybe the 3 strikes you're out policy, then we're able to say that we now have a no-show policy. And that in and of itself may
Be sufficient.
Okay. Can I make
Yeah,
a
the
motion to pass just the 3 strikes that you're out section of the no-show policy and make that our initial no-show policy, which can be updated in the future if the board so deems and we find out that if you can charge a fee or not?
Okay, and that the director and our medical director will come up with phraseology for our staff to use in communicating it?
Yes.
Okay, that's the motion. Has it been seconded?
I second it.
Been moved and seconded that we approve this as discussed. Okay, and we want to do a roll call vote?
Peggy Cavallo,
Yes.
Dr. Johnson,
Yes.
Dr. Nolan,
Yes.
Dr. Fletcher,
Yes.
Commissioner Cowles,
Yes.
Commissioner Bertling,
Yes.
Chairman Bailey.
Yes. Okay, so Jessica, you have enough information and you can put that in our minutes?
Yep.
All right. And the next item on the agenda.
out of health district policy.
Okay,
So thank you for bearing with the sort of tedious things but they're
Need to be
important
done.
in the big scheme of things. So thanks for the time and effort that you're putting into this. So the out of health district policy arises because we have a percentage of patients that have a mailing out address outside the health district. So that could be in Washington, that could be in Montana, or that could be even in another county in Idaho. Now, I thought this was a bigger problem than it was. And when I went to look at the numbers, it's not a huge problem, but about 2.7% of the patients have out-of-state addresses. So I looked at all the unique Social Security numbers out of 3,370 unique Social Security numbers. 91 of them had out-of-state addresses. And if you consider that each patient probably has a little over 2 visits per patient a year, then that's 200 visits worth. So the point is, and the point of the policy would be that there's this percentage of patients that are seen outside of PhD's health district. And because PhD is funded or at least partially funded by the 5 counties of northern Idaho. No other state, as far as I know, including Washington, which is the biggest number of patients who come over to seek our services. Washington State doesn't contribute to the funding of Panhandle Health. So, the question is what to do about that. So the proposal is to charge a $20 out-of-district fee for any clinic patient that's seen for any clinical services provided to individuals whose mailing address lies outside the Panhandle Health District. And there may be some nuances to this as well that I haven't considered, but I'm not sure that we should turn these people away outright. But I also don't think that they should be subsidized at all by the district, by the county.
Can I make a point on that too?
Dr. Nolan?
My understanding would be then 0% of those people are Idaho Medicaid.
That is correct.
If they're living outside of Idaho, they can't be Idaho Medicaid.
That's correct.
I
I would assume, although I don't know how you could be Idaho Medicaid with the Washington address.
You have to be pulling some
Stranger
kind of
things
trip.
have happened.
Yeah.
So.
So during the in-processing process, do we determine that this is a social security number? Their primary residence is not in Idaho or not within our District 1?
That's what I did when I went through the numbers, was to pick out those patients from other states. And I can tell you the exact number if you want, but
Well, what I'm trying to say, how do we determine that they would need to be charged this out-of-district fee?
yeah, it's a good question. And I would say probably the best way is mailing address, but
Get a driver's license.
driver's license.
Most
Yeah,
medical
so
places,
I'm
Xerox
certainly
copy of driver's
open
license.
to other
Yeah,
ways
driver's
to
license is good,
verify that.
but not everybody drives either.
But almost everybody has a ID or a driver's license.
Yeah.
Chairman, if I may, I have similar concerns to this fee as, to our statutory charge a fee when there's not a service being provided. I certainly agree with the concept of not subsidizing folks that don't live or pay taxes within the district. I would just want to make sure that if it's a fee that we establish, that we have the legal authority to do so and it's appropriately calculated.
Eric, I agree with you. But this is not for a missed fee. This is for an actual service that is being provided. This is not a missed. This is you're coming and using our clinic at
Correct, but it would be
good prices.
It would be in addition to our already calculated actual cost. So it's a fee on top of our actual cost.
Mhm.
And I don't think we have statutory authority to charge beyond our actual cost. That's the concept that I'm coming from. Again, not disagreeing. I'm just bringing up
So that would only per se be as if the service was being calculated at the actual true cost to the best of our ability, which most services are not probably currently doing that. If you're running through that logic. The other one would be you could look at costs currently would be cost not subsidized from the county. So if the county didn't subsidize us, what would be the true cost of all the services? And that's where we'd hopefully get to. But the idea, so I think that it's part of, I believe we can charge more than a cost. Is there a statute saying we can't charge more than a cost?
yes. Yeah,
Where does it say that? Is that?
there's a couple of citations in statute that speak, and again, this is where I think Dr. Pennock has shared that there's, I suppose, different ways to interpret it, but generally, I mean, I can read it to you.
Let me read it to you one more time. So
Yeah.
it says, to establish a charge whereby the board agrees to render services for an amount reasonably calculated to cover the cost of rendering such services. So cover the cost of rendering such services.
And an out-of-county person is not a service.
But what if it were labeled a penalty? In other words, we're not obligated to cover anyone outside of the district, and so we're penalizing you for crossing state lines. accessing healthcare in a state that
It's not
that
yours.
that is not your state. I mean, I think it.
Permanent residence.
Yeah. So in other words, it's not a cost; it's a penalty. I don't know. That might be something to run by the authorities that be or whatever.
Isn't appropriate. Dr. Fletcher?
Yeah, I have some apprehension with this, and in no particular order. Number one, if due diligence was performed on the fee schedule, we should be income neutral. In other words, our services should be paying for themselves, and we're not being subsidized by the counties. So that we deliver services to someone from Washington or someone from, I don't know, somewhere else on planet Earth, a Frenchman, for instance, then the county taxpayers are theoretically are not subsidizing. I mean, that's if we've done our due diligence on the
Certainly
first
our
item we
goal.
discussed.
We're not there, but it's certainly our goal.
Okay, got it. Number two, I don't know if you can have dual fee schedules. Something in the back of my brain tells me there are CMS rules that are going to frown upon dual fee schedules for the same service.
Point taken.
I'm not even sure that's legal. And then my last argument would be, hallelujah, that we would be attracting people from outside the state. I mean, I see no reason to turn anybody down or to penalize
I
them.
agree.
I mean, for crying out loud, that we would be so good that they would want to come see us. Well, give ourselves an applause. If you have apprehension that maybe you're going to have someone game the system, they'll come sneak into one of our clinics, get all their services, and then run back to Washington and say, well, come catch me if you can, like the gingerbread man. Well, if it gets to be a problem, then have them pay up front. But it would be the same fee. You see where I'm coming from? Those would be my thoughts.
Thank you. Any other comments? Points?
I like the idea you're talking about too, is that I think partly is the clinic hasn't been run neutral, like budget neutral.
Right.
So getting to that point, like you're saying, then it shouldn't matter to the counties or anyone in Panhandle, as long as they're not excluding access by filling up the docket. So we just have to track and make sure, like, are we getting wait lists of locals that would be a different thing to address. It's, again, still a good problem. but the idea is we wanted to make sure that we're not pushing back visits from Panhandle residents for out-of-state folk, ideally. But we're not there yet. I don't think so.
Or even legal residents of the United States.
Mhm.
Amen.
Well, and Tom, you make a good point. I mean, I'm thinking from the aspect that we're not income neutral, so I'm thinking that it's
That's where I was.
yeah, when we get to that point, yeah, the more the merrier. So it makes more sense to not charge them if we're then it's just more income to the facility, which is great. My initial thought was, we're incurring fees for other people, but if we're income neutral and beyond, then it's great to have them.
Yeah, I was probably looking more at the short term than long term, but you've convinced me that I agree with you over the long term if we're budget neutral. And I also thought it was a bigger problem than it probably actually is. So that's the other good news. But I'd actually be interested in what Commissioner Korn thinks about this question. Are you still there? He's not there.
Ron, are you still with us?
I guess not.
His microphone is still slashed. Okay. So,
We have other commissioners here. I mean, but
yeah.
Well, yeah, absolutely.
Yes, please.
I would agree with everything that was said about the fact that this is being 2.7%. I think there's other areas to go after. and to turn people away, because you might have someone that is here on vacation in the summertime, heard about it, and that's how they got into the clinic.
Uh-huh.
And so they're spending money in the community. I think there's other areas we need to focus on than that one.
I wouldn't disagree with that. But I thought it was important enough to bring before the board to discuss it, so. Good.
Gerling, thank you. Yeah. Peggy, did you have a comment?
I think the only comment I have, and well, first of all, I would say that a lot of people from out of the district come back because oftentimes when women establish with a provider, and if they're headed off to college or if they live in Spokane, they're willing to drive back to see that person they have an established relationship with. So yes, I don't think they should be penalized, but I think what would be helpful in the future is instead of having these items as an action item, maybe have them brought up for discussion if they're not emergent. So we can have the discussion, get all the questions out there, and do the research.
Good point. Okay. So after this discussion, Dr. Pennant, would you like to pursue this further?
Not necessarily. I think we can put this one to rest specifically.
Okay. So
If the board's comfortable
that one
with
has been discussed and properly addressed. Okay, thank you.
I just wanted to make sure you knew the numbers and
Yes.
see
Well,
what your response to that was. I initially looked at it as subsidizing people from out of state,
sure.
which didn't sit well with
There's
me.
that aspect to it.
Yeah.
But the bigger picture, I guess, is that we are here to provide healthcare services for individuals that need it.
Good.
Okay. As long as they're legal aliens. All right. Next item on the agenda. Okay. Panhandle Health District's report, Director's report. Eric?
Thank you, Chairman. I just have one brief comment as we close out fiscal year 26. I just want to commend all of the staff for their hard work over this past year, as is evidenced by the program updates that are in each of these packets. Thank them for their continued service and the hard work throughout this fiscal year.
Agreed. Thank you. Yes.
Yeah.
Commissioner Bertling.
I'd like to make a comment. I had a septic inspection done, and I will say that Tanner was very professional about his job. And
Did you pass?
yeah, my drain field's not.
All right.
And it was, really a good experience.
Cool.
Good.
Sure.
Yeah, agreed. I've had that done. I had to expand my drain field, and your personnel are very professional and do a good job. Thank you, Jason. Yeah. And I think at the time they were under you.
Could have been, yeah.
Okay. Well, I appreciate everybody's contributions and participation in our discussions and considerations. If there's no other items, we will go ahead and adjourn. The time is 2:38. I appreciate everybody being here.
So, I'm going to call Beverly or Wall. They are the firm that. Right, no, I know. But there is the matter that, currently they are actually